Welcome to our next presentation on systems of prevention. My name is Adiola Adeyemo, and I am a communications graduate research assistant with Adapt. It is my pleasure to introduce our next speaker, a pioneer in prevention research, Dr. Zili Sloboda. Dr. Sloboda is the president of Applied Prevention Science International. Throughout her career, she has dedicated herself to establishing the field of prevention science, developing an international cadre of prevention professionals, and studying the relationship between training in prevention science and implementation of evidence-based prevention interventions and policies. Her research has focused on substance use epidemiology, services research, and the evaluation of substance use treatment and prevention programs. She has held several roles with the National Institute of Drug Abuse, co-founded in the US, and EU Societies for Prevention and Research, and written seminal books on substance use prevention and prevention science. She has received several commendations for her work from the National Institutes of Health and the US and EU Societies for Prevention Research. We are grateful for the opportunity to learn more from Dr. Sloboda as she presents today on systems of prevention. Welcome, Dr. Sloboda.
Thank you very much. It's a pleasure to be here. Hello, everyone. I would like first to acknowledge my long-term colleague, Susan David, who helped me prepare this presentation, and I believe she's in the audience. The previous speakers provided a framework for my talk on building a prevention service delivery system. The first part of my talk will outline what is meant by a prevention service delivery system. I will follow up with a graphic of what I think a national prevention service delivery system could look like, and end up with the need for a culture of prevention to sustain such a service delivery system. If we look at a healthcare service delivery system, something we are all familiar with, we see three major components: consumers who seek care, health professionals who deliver the care within a structure or context provided by a healthcare organization, such as a health maintenance organization or home healthcare organizations or agencies and clinics. Two key elements of this system are having trained and qualified healthcare professionals and medical care services that have been found to be effective. The provider organization is also key, as it usually is a structure that is identifiable as a place where this effective healthcare is delivered by these qualified healthcare professionals. Funding for these services, as we all know, generally comes from private health insurance, public funding, or out of pocket. Now let's look at the existing prevention service delivery system, and I use the term service system loosely. The key elements of the system are the consumers, who may or may not seek prevention services. There are the prevention professionals who vary not only in their training, but also may not, be certified as prevention professionals. And the prevention services that are being delivered may not be effective or evidence-based. Furthermore, although provider organizations may exist, for example, community coalitions, schools, county boards, and in some cases, law enforcement, there's generally no prevention structure that is identifiable. And funding for prevention services is primarily from public funding, often federal, state, or from foundations. So the next several slides, I will be pulling out the components of the existing prevention service delivery system. So we'll start with consumers of prevention services. Who are they? So the next few slides, I'm going to be outlining my concept of what these populations look like. So if we look at a population, we can establish that there are a number of groups in that population relative to psychoactive substance use. And here I outline 8 groups. And each of these groups would require different types of services. Others may define this group differently, but let's use this then as my sort of model, what we're focusing on. So I see 8 groups: those who do not use substances and are not vulnerable, but who need prevention program to reinforce their no use status. There's the groups who do not use substances, but who are vulnerable, such as children of substance users or those who are stressed because of poverty, abuse, etc. There are those who initiated use and may or may not experience consequences. Group 4 would be those who meet a DSM diagnosis for substance use and need treatment, but do not utilize treatment. Then there are those who have the diagnosis for substance use treatment and actually use it. There are those that have met the diagnosis for treatment and who sought treatment but didn't receive it. We know that there are quite a number of those. And then there are those who receive treatment who drop out. And then, of course, the ones that finally go to complete treatment and are recovering. In the next few slides, I've tried to put numbers to these groups using the National Household Survey on Drug Use and Health. So for group 1, we find that approximately 60% of persons aged 12 and older use at least one psychoactive substance listed here in the month prior to survey. Of course, this is assuming an unduplicated estimate. That is, that people may not be using more than one drug. But this means that 40% of the population, or 110 million, did not use any psychoactive substance. For group 2, we have an estimate from a paper by Lipari and Van Horn, published in 2007, of 8.7 million children who have at least one parent who had a substance use disorder. For group 3, we have not really good information on this group about this is the population who initiated use but may not experience consequences. I really couldn't find a lot of information on that except use patterns. So this is an area that really requires more focus. For group 4, of the 20.8 million people aged 12 and older who in 2019 met the criteria for needing treatment, 18.6 or 92% did not receive treatment. And we see that 2.2 million or 10% of those who needed treatment received treatment in the year prior to the survey. And let's not forget those 236,000 or 1.2% who needed treatment, who made an effort to get treatment, but did not receive treatment. Then there are those who needed treatment, registered for treatment, but didn't complete treatment. And we have estimates from Lipan and colleagues that estimate that this dropout rate is 30%. And I think that's pretty much what we've been finding across many studies. In some cases, of course, those dropout rates are much higher. And finally, group A are the 2.6 million or 12.2% who needed treatment and actually received treatment. So that gives us an idea of the proportions in the population in these groups. And looking at a pie chart, you can see that roughly 110 million should receive prevention services, while 2.2 million should receive treatment services. And we can see that currently, the distribution of federal funds directed to substance use does not seem to reflect this need that I put forward. We saw that a large number of the population needs some type of prevention service. And to better understand what those prevention services might be, I thought we might want to look at the issue of vulnerability. Most of you are probably familiar with risk and protective factors. In 1992, two significant works were published that summarize research, longitudinal studies that were conducted during the 1980s following children into adolescence and adulthood to see what factors seem to be associated with the onset or initiation of substance use. And so Hawkins focused on his colleagues focused on what were the factors associated with initiation of substance use, looking at mostly risk factors, while Glantz and Pickens are looking at the factors that were related to progressing from use to abuse. The general risk factors, as you know, are measures of behavior or psychosocial functioning, including attitudes, beliefs, personalities, that were found to be associated with the use of substances. And these included contextual factors such as laws and norms favorable to substance use behaviors, related to availability of substances, economic deprivation, and perhaps neighborhood disorganization. While we found individual and interpersonal factors, including psychological measures, family history of substance use, attitudes towards substance use, family management, family conflict, family bonding. These are all would be putting somebody at risk for substance use. And then the Glantz and Pickens work, as I said, indicated that contextual factors played a significant role in the initiation, but they found that the individual or interpersonal factors were more likely to explain the progression from use to abuse. And then, of course, there are the protective factors that appear to prevent the use of psychoactive substances. And these included strong bonding to family, school, community, and peers, particularly peers that have pro-social attitudes and support pro-social behaviors. In this more recent research on genetic basis for substance use and the impact of the use of psychoactive substances on neurological processes have helped to better explain what processes underlie, what are the mechanisms that underlie these risk factors and protective factors, which really are more indicators of what's going on. These findings and those from other research show the importance of the interaction between nature and environment. So, for instance, studies indicate that strong positive parenting or supportive school climate can facilitate positive social development for youth with self-regulatory problems or who have biological behavioral precursors to negative behaviors. Other studies using multi-level modeling techniques and use of spatial analysis have shown the influence of children's neighborhood context on their behaviors. Putting all of this together, we can see from this simplified model of the etiologic process where vulnerability to problem behaviors occur. It is the interface of the person, the personal characteristics, with his or her micro level, which would include family, school, peers, etc., and macro level environments, including I added climate change to this recently. And that's where the interface defines risk or protection. So the influence of these environments is called socialization. And we can see how socialization takes place at many levels, and socialization agents exist both in the micro level and the macro level environments. So what does this mean? Well, it means that when we are born, We do not have an innate culture. Culture, attitudes, beliefs, language, behavior, all learned. This learning process is socialization, and socialization is a lifelong process. And as we have just seen, we are socialized by a large array of socialization agents throughout our lives. Socialization takes place through observation and guided learning in a positive environment. Thinking about vulnerability and socialization then helps us identify points for intervention. The stars in this graphic indicate these intervention points, and you can see they are between the micro level and the biological of the person, the macro level and the person, but also between the macro and micro level. I think that's important also for us to see and to identify. What are the implications of these new ways of looking at vulnerability for prevention? We begin to see and think about prevention as a socialization process, and therefore is seen as helping people make socially appropriate and healthy behaviors. Both socialization and prevention programming share similar processes. They both use evidence-based practices to help individuals interpret cues in their social and environmental contexts. They help individuals learn and practice new behaviors, such as how to resist offers to use substances, and they help individuals weigh the potential outcomes for the performance of these behaviors within their own contexts. This means that prevention professionals may either train key socialization agents from the microenvironment, parents, for instance, and teachers, to help improve their parenting, family management, and in case of teachers, classroom management skills. These are called behavioral interventions as they directly focus on behaviors that are important in helping to support children and adolescents. But prevention professionals become socialization agents themselves by directly engaging in the socialization process, say through a school-based curriculum. In the prior section, we talked about consumers of prevention services and their needs. And now I want to talk a little bit about prevention professionals who would provide these services. So looking at what makes a profession, and I looked at sociology of professions. The sociologists have defined professionalization as having a systematic body of knowledge, skills, competencies that have their basis in theory and research. A profession has the authority to define the problems or issues it has to address and how to treat those issues. A profession as a group has sanctions regarding who is to be admitted into the profession and how they are trained. Professions have their own codes of ethics based on principles of services to others, and professions have their own culture that includes what institutions or systems are necessary to carry out their functions. And many of us in the field come from other professions in many ways. And I think if you look at this, if you're a psychologist or you're a medical physician, and you look at this, you should resonate with you that, yes, that sort of defines what my profession is about. But what about prevention? Where are we in terms of this professionalization continuum? We have a lot in place, actually. We have a systematic body of theories, skills, and competencies, and these have been acknowledged internationally. The Society for Prevention Research, both here in the United States and in Europe. We have the European Drug Prevention Quality Standards from the European Monitoring Center for Drugs and Drug Abuse. And we have what I think is a really extremely important contribution to the field, the International Standards on Drug Use Prevention that was published by the United Nations Office on Drugs and Crime and the World Health Organization. And my group has helped develop a universal prevention curriculum that we were with funding from the US Department of State, and we have been doing trainings in this curriculum internationally. And we have actually moved it to a virtual platform, which we call the Foundations of Prevention Science. The field is working on having authority to define the problems and how to treat them, to address them. Particularly working with these new concepts of vulnerability. And we have other pieces in place, some of them I mentioned already, that sort of help us define what the problem is. I mean, just having a definition of prevention that's universally accepted would probably help a lot. And then, of course, we have now in place evidence-based prevention interventions. The term evidence-based has been being used widely around the world, and I think that's been a very significant piece of showing how we've progressed in the field. We have both the UNODC standards, which I will talk about, and registries on these evidence-based practices. Although some countries have sanctions in place regarding the credentials needed to supervise, coordinate, or even implement prevention programming, there's no international credentialing and licensing system in place to oversee the training that prevention professionals require to implement prevention interventions in their communities. However, we are moving in that direction, so I'm very optimistic that we will have those in place too. We have codes, ethical codes in place that stress the ideal of service to others through the prevention think tank. And again, the European Drug Prevention Quality Standards lays out ethical codes of conduct. And finally, there's no international culture of prevention that would include the needed institutions necessary to carry out our functions as prevention professionals. The science of prevention is also extremely important for defining what prevention professionals do. And it draws on several different sciences. I mentioned here epidemiology, which helps us define what the substance use problems are, who's affected, looking at etiology, looking at consequences. We have theories that define what principles we apply when we develop interventions, when we deliver these interventions. And we have what I think are the heroes in the prevention field are our research methodologists who have been able to demonstrate that evidence-based interventions, how they operate, to demonstrate their effectiveness, and to talk about how they work, how they operate. So we better understand the importance of implementation fidelity, and of course, monitoring and evaluations that can be used to monitor what's going on, to establish whether programs are being implemented with fidelity, and where we would need to improve our programming approaches. And as you can see, there's an array of other types of skills that a prevention professional needs to have in order to deliver, implement, oversee, et cetera, evidence-based prevention interventions. Many of you may have seen variations of this model that is a guide for prevention professionals to help them walk through the planning and implementation process. This model was as an adaptation of that came from the European Drug Prevention Quality Standards manual. And the cycle is important as it reminds us of what prevention professionals need to do to help prevent substance use in their communities. They need to do a needs and resource assessment all the way through towards selecting the intervention, implementing it, monitoring it, and reviewing it, and to determine whether it needs to be improved. Excuse me, I'm having a little bit of a throat problem here. And I want to underscore the importance of monitoring evaluation that should be integrated into this process from the beginning. So we can see how prevention science guides the tasks of prevention professionals in their work. The great challenge is reaching those who deliver prevention services with this knowledge. And the field includes those who self-identify as prevention professionals, but even within that group, we know that people come to the field with diverse educational backgrounds and different prevention experiences. But there's also a number of people who do not consider themselves, would not say that they're prevention professionals, but who are doing prevention-related work. And many of us know these people. They're social workers, they're psychologists, they're teachers, they're law enforcement officers, they're healthcare workers. So as we want professionals delivering prevention services to have the same knowledge, skills, and competencies to deliver evidence-based interventions and policies, we therefore need to use a variety of methods to reach and to train these prevention workers so they deliver the most effective interventions with the highest quality. And as we know, there is no standardized training available to prevention professionals, although there are now universities that are offering courses in prevention science, both directly in degree programs, but also in continuing education programs. And of course, there are others such as not-for-profits, government-sponsored groups that are delivering training, but there's not consistency across the content or even the delivery style of this training. I think what's really exciting for us in the field is the readily available information on evidence-based prevention interventions and policies. I mentioned the international standards document that was developed by the United Nations. Let me just give you a little bit of background on that. The intent of it was to summarize the available scientific literature to find out, to identify what is evidence-based. The reviewers use very rigorous standards for reviewing this literature. They then selected what would be considered evidence-based and looked at what are the key components or features of these interventions and policies. The international standards also lays out some components and features of an effective national substance use prevention system that I sort of build on in this discussion. And ultimately, the intent was to help policymakers support evidence-based programs in their countries. The way that standards is laid out, it looks at these interventions from a developmental framework, from infancy and early childhood through adulthood, looking at the interventions within the settings that they take place, and also what the target populations are, whether universal, selective, or indicated. And what is included in the standards for each interventional policy that's been found to be evidence-based. There's a description, a rationale for it, and a summary of the evidence, and a list of the characteristics that have been found to be linked to positive outcomes from these interventions, as well as, when available, whether there are negative outcomes or no outcomes whatsoever. The standards offers identifies guidelines and tools and resources that prevention professionals can use. And as I mentioned, there's a chapter on the critical components of a national drug control system, which would be a prevention system. This is a summary of putting everything into one graphic, which hopefully you can see some of it. You can see across the top is the developmental age groups that I mentioned. Along the left side are the settings. Then within each of those are boxes which outline strategies that have been found to be effective. The stars indicate the strength of the evidence to support these strategies, and the color outlines on the boxes represent whether they are universal interventions, that would be the green, whether they would be selective yellow and indicated in red. And just to give you an idea of what you could find in the standards, and I sort of summarize this, you can look at it from a content perspective. What are the elements of the content? Here we're looking at parenting skills for middle childhood, 6 to 11 age children. And you can see that warm child rearing, positive monitoring of free time, and looking at friendship patterns, becoming role models. The content of these strategies, this has been demonstrated to be effective. Whereas if you undermine parents' authority, or if you provide just information on drugs, that's not been found to be effective. The structure is also important of these interventions. How are they put together? Here with these parenting skills programs, those programs that have group sessions that include activities for parents, children, and then combined as family, that are highly interactive, have been found to be effective. Those that focus exclusively on the child have not been, of course, lecture we know is an only means of delivery, have been found not to be effective. And of course, delivery, almost every evidence-based intervention requires additional training. That's really important. So this gives you sort of an idea of what you would find in the standards documents. But it should be emphasized that, like a well-made cake, that all of the components or ingredients of these interventions must be in place to be effective. So if you're baking a cake, just having the ingredients doesn't really help you make the cake unless you're an expert baker. You really need to know how to put it all together. And that's, I think, where registries are important. There are several registries of evidence-based programs and practices in the substance use prevention field, excuse me. Their purpose is to assist prevention professionals in selecting the best programs that meet the needs of their target populations. And the best registries identify prevention strategies with the strongest available evidence of effectiveness, and they identify how that identification process is carried out. Specifies what populations they have that have been targeted for the evaluation studies, and also provide are searchable, that you can get in there and you can pretty much easily find the information. The problem is that many of them are not updated in a timely fashion. Sometimes if you look at compare registries, you'll find the standards of evidence may vary. And of course, that presentation, the ease of use also varies across registries. And I just listed a couple of what I think are really good registries on this slide. Many of you may be familiar with Blueprints for Healthy Youth Development. There's Strengthening America's Families that focus primarily on family or parenting programs. The European Monitoring Center on Drugs and Drug Addiction has the best practice portal that has been recently updated. And within the United States, the number of the states have been developing clearinghouses or registries, and I mentioned the California evidence-based clearinghouse here. And so as examples of what I think are pretty good registries. Despite the availability of all these resources and this place where we are in terms of prevention, science, et cetera, the use of and support of EBIs has not been completely embraced across the country here in the United States or around the world. And although there isn't a lot of information about the implementation of evidence-based interventions, there are a couple of studies that you can see there are somewhat dated. Chris Ringwald and his colleagues have looked at this information, looked at this issue. Here we have middle schools. He looked at middle schools. And then there's work that I did between 2001 through 2006. We looked at 220 middle schools in 6 metropolitan areas across the country. And both Chris and I found that there isn't a broad embrace of evidence-based programs at middle school. And then when you get to high school, there's even less. There was less. And I don't know if these figures are updated. If anybody in the audience has information on updates to this, I think it would be wonderful to share that. We get to, in our study, where we found out that there was no evidence-based programs, and you can see that it's mostly activities. And many of you who've been working in high schools know what before COVID anyway, that this is true. There are a lot of group activities that high schools have in place, but they're not evidence-based. And why? What are the reasons that explain why getting evidence-based prevention out there in the community? There are knowledge gaps, the stigma associated with, I guess, being science-based in some communities, is having access to a delivery system to deliver them. And the big challenge is, of course, workforce, having trained prevention professionals to deliver those interventions. And there are a number of other things. And of course, we cannot leave out cultural competency, language, social competencies, and related issues. So we spoke of consumers of prevention services. We talked about prevention professionals. We talked about evidence-based interventions. And now I'm going to turn to the final component of the system, the provider organizations. Looking at provider organizations that deliver prevention services, there are those organizations that I mentioned, I think earlier, the community coalitions, county boards, schools, prevention providers. But as I also mentioned, we have the healthcare system that delivers, that might be delivering prevention services. What we also don't know is how much overlap in prevention services exist. My guess is, maybe I'm a pessimist. I don't think there's a lot of overlap between these service delivery systems. And that is why we encourage prevention professionals who work at the community level to do not only a needs assessment, but this emphasizes why it's important to do a resource assessment, because they need to work with other organizations to not only integrate a service delivery system, but to assure that evidence-based interventions are being delivered with fidelity to the appropriate target population. And of course, we don't want duplication of services. That is not necessarily important. That's not helpful for anybody. So how can we address all of these challenges? And I offer as a solution would be having a national prevention service delivery system in place. And several of us in the field have been thinking about what a prevention service delivery system should look like. As I mentioned, not many countries have a national prevention delivery system at any level, not only at the national level, but certainly not even at the local or state level. But we're certainly at, you can see we're certainly at a point where we can have such a system in place, providing epidemiologic data, trained prevention professionals who deliver or coordinate the delivery of evidence-based prevention interventions and policies that we can deliver them at all levels to families, schools, the workplaces, through the enforcement of laws and regulations, and through well-designed media messaging. So going back to our etiologic model, sort of identifies the places where this may, the settings for these are the components that we would have in a national delivery system. We would have family prevention intervention services, school-based prevention services, workplace, which I think has been neglected in the prevention area, but we have some really great evidence-based interventions and policies that we can integrate in the workplace, environment-based interventions, as well as media. Excuse me. So what we need now is a system of trained prevention professionals who share the same training and are credentialed. And of extreme importance is having a monitoring and evaluation system in place to assure the services meet the needs of the population, are implemented with fidelity, and demonstrate the desired outcomes. Furthermore, such a system should provide updated information on available evidence-based interventions when they're ready, so that we can truly address the needs of our communities. And of course, we need a strong funding system in place. I know this looks a little complex. I know it's very complex. It may be difficult to read, but I sort of took those elements those components we just talked about and put them together and showed how into a system. I'm not going to go into a lot of detail now because of time, but you will have these slides and you can look at it. So this is just a first cut at this. Obviously, some other people might look at this and want other things, other components involved in this, but at least it's a place to start the discussion about development of a national prevention service delivery system. But we also need to have this system operate within a culture of prevention. And I think COVID certainly has underscored the importance of having a culture of prevention. And what does that mean? To me, it means that it's understanding what the etiology or cause of the problem is. It's recognizing that we have responses. We can actually address these causes, these problems. It's a belief, as I indicate here, that evidence-based prevention does work. And it's also having support for prevention efforts in a variety of settings and around a variety of issues. We know the evidence-based interventions have outcomes other than preventing substance use, that those addressing children and adolescents show that they improve academic performance. And so it prevents suicide ideation. We know that prevention works across the board, addressing many, many problems of our populations. But we also have to recognize that prevention alone isn't enough to reduce the negative impact of substance use on families and communities. We can see that again using COVID as an example, that just preventing COVID transmission isn't enough. We really have to treat those people who have been affected and get them well. So we need an array of services. I present this spectrum of services here that was developed, published in the 2009 by National Academy of Sciences. And I think we need to end the fragmentation of community-based prevention and treatment programs and integrate them into one service system that will strengthen public health and safety. And I know this is my dramatic slide where I overlay my 8 groups and this array of systems, so that you can see that if we have such a system in place, all the services that these 8 groups would need would be there for them. I want to thank you for your attention, and I'm happy to have any if you have any questions or comments. I appreciate them at this point.
Thank you, Dr. Sloboda.
Thank you.
We do have a few questions that have come in.
Oh, good.
Yeah, the first one relates to cultural humility and ethics. And one of our viewers, and you touched on this today, one of our viewers also saw some of the recent presentations you've been delivering through those webinars over the last few weeks with another international organization. And I think it's a timely and also very relevant question for this summit. How do we ensure that the evidence-based programs that are technically official reflect the needs of the communities that we're working with? Truly match those?
That's a wonderful question. And I want to underscore that the Prevention Technology Transfer Center's webinars on this specific topic, we're going to be actually addressing that. What we've done with what we're doing in these webinars is including ethics that are informed by social justice and by cultural humility into the planning process, doing the needs assessment, going all the way through in terms of selecting the appropriate prevention program for groups in the community. One of the things that I found working with communities, there are groups that are left out, and how do we get them involved and participating? And that requires cultural humility to be able to reach out to them. And I think that should be part of our training process. When we were preparing this webinar, one of the things that we shared was when we went to graduate school, nobody told us how to work in a community. And it doesn't take 6 weeks. And that actually has implications for funding, because my experience has been 18 to 24 months to really get into a community and to involve all groups within that community, using a variety of different methods to involve them. It takes a long time. It's not, you can't just walk in and just do a prevention intervention. So that's another thing we really need to have our funders better informed on cultural humility, so that they will give more time to achieve those ends. And maybe we need to define different endpoints. We haven't done that appropriately either, to show when our benchmarks, when we go into community coalitions have set up benchmarks, for instance, that maybe this should be part of the benchmarks. So we need to really integrate this more. This is kind of a new concept, I think, integrating all of these things with the planning process. But my experience with talking to prevention professionals, we really need to begin talking about these things and making them, and coming up with solutions together.
Absolutely. And on that note, it's a great segue into the next question, which is really about involving youth in the whole process of this prevention credentialing and certifying prevention specialists. And the question is, what, if any, role do you see for youth in prevention credentialing, especially considering the youth-to-youth effect and the impact that can have in working with each other? Where's the opportunity for their voice in that credentialing process?
Wow, I definitely think that there are places for youth. In fact, we have student assistance programs in schools. We have other types of programs that have trained youth, particularly adolescents. I think that we really haven't done a lot with younger age groups, but we do have things in place. This question fits in very nicely with, for those of you who know me, I'm like all over the place and stuff. One of the things I've been working with a colleague in Europe around is developing prevention science curriculum for high schools. I think some schools have been delivering prevention science in high schools, and I think that's one way of getting young people more aware of what's going on. And there could be some kind of credentialing program for high school youth. I know quite a number of people who've been involved in prevention in high schools that have become prevention professionals as they grown up and into adulthood. So I think we need to establish that link, because I think prevention science, for instance, has implications for so many things that I think high school students would certainly be open to, and I think that would help them a lot. So yeah, some kind of credentialing program in high schools would be a terrific idea.
Thank you. The next question relates to ACEs, but moving beyond that, this viewer took out from the ACEs study the impact of parenting education, right? And they're asking, should we consider national parenting education campaigns akin to the campaigns of smoking and seatbelts of the past, perhaps national multimedia messaging that teaches parenting behaviors and practices generally recognized as supporting that healthy development in children?
Mm-hmm.
What are your thoughts on that, Dr. Sloboda?
It's like I have chills in the audience. There are a group of us who are actually working on that. And I think the next two speakers later, Dennis Embry and Tony Biglin, as well as Denny Fishbein, will be talking about exactly that topic. So it's, and so I think that this is really important. Yes, I think we should be having those. I think we should be having, I would love to have a campaign of just teaching parents or telling parents about prevention science and how important it is that they support prevention in their communities. So I think there's a lot we can do. And as I said, this is just a great segue for the discussions this afternoon. But yes, I think that we in the field are thinking about exactly that. So we're working on that.
Wonderful. Okay, this question comes up a lot. In working with our HIDA communities, we do have this public health, public safety framework, and we are really trying to flesh out and identify where the exact nuances are in public health and public safety collaboration, right? To really bring it to life in the most effective way. The question is, evidence-based prevention often ignores cultural competence. I'm sorry, no, a few more just came in. Let me go back to the one that I was looking at. Here, what role should properly trained law enforcement professionals play in the K through 12, so kindergarten right through high school, drug and violence prevention space? I know that we've kind of been noodling over this for a long time, and we stumbled upon some answers in that latest group experience, some of the international colleagues. But do you want to speak to that kind of from your space and Applied Prevention Science International?
Well, many of you may know that one of the studies I did was working with DARE officers. And that was always a criticism, why should a law enforcement officer? And again, I don't think it's, it's not the label that's on your forehead that's important. It's the training that you have in prevention science and in the delivery of prevention interventions. And many of the DARE officers that I worked with were fantastic. And we trained them in prevention science. And when they understood prevention science, and we wrote in a paper of this, of course, the implementation fidelity went up. And they relate well to the children. It depends on the age group. But I think the law enforcement has another huge role that we really haven't explored well, and that is in the enforcement of laws and regulations regarding availability and accessibility of substances, legal substances, tobacco, alcohol, and of course in some places cannabis, to young people. And there are evidence ways of doing that, and we need to involve law enforcement. They should be part of the prevention spectrum in the community. Again, the United Nations Office on Drugs and Crimes is right now developing guidelines for law enforcement officers in schools, and I've been very fortunate to be involved in that discussion. And I see that link between prevention and law enforcement. They should be our partners.
Thank you. The question that I stumbled upon earlier, which is a really great question and kind of blends a lot of the discussions we've already had up to this point on the cultural piece of things. Evidence-based prevention often ignores cultural competence. And that really comes through when trying to implement a program that has been designed and implemented and evaluated and studied, right? And maybe another setting, another population. maintaining fidelity to that is hard when there might be cultural variables influencing, right, the potential outcomes.
Yes, absolutely.
So understanding that oftentimes cultural competence isn't fully considered, and social innovation is also not fully considered in the delivery and in the implementation of that strategy. How do we approach that? Anything else you'd like to add to piggyback on things you've already said?
Yeah, no, I think that is a challenge to us, because, as correctly stated, a lot of the evidence-based programs have been conducted in Western populations, have been conducted in perhaps middle income groups. But we are having experience working with the developers to test these out in different cultural settings. I think that we have some guidance of how to do adaptation correctly. In fact, last month, our company, Applied Prevention Science, has prevention talks monthly, and last month we had Felipe Castro talking specifically about this topic. And if people want to go to our website, it's recorded there. But there's so much more work that needs to be done in this area, absolutely. I guess one of the things that I'm concerned about is funding for prevention research to address some of these issues. I think funding has been less now than it was in the past. So that, I think, is an issue. But yes, I agree. And I think we need better guidelines to help people do this. One of the things is understanding the essence or the guts, the theories that drive the intervention, why it was developed, what are the factors that explain the outcomes, understanding that and working with the developer to adapt it for the cultural needs, I think is the way to go. But first, to understand how the intervention's working. What is it that works? And I know you're looking at time.
Yeah, no, Dr. Sloboda, we were at time right now, but there is one really rich question that came in that I know that everyone kind of chews on every now and then. There are different frameworks for thinking about a continuum of prevention, right? With the primary, secondary, tertiary strategies, as well as universal, indicated, selected, and ways of blending that, like SAMHSA's done for us in one of their documents. But we often find that people are operating in silos of some sort, right? With harm reduction kind of staying in its lane, but also describing themselves as prevention, right? And primary prevention, like too good for drugs and other strategies, defining themselves specifically as prevention. And this happens on occasion, right? But how do you think through, and the viewer's question is specifically this: it seems that the definition of prevention has expanded beyond the IOM's, the Institute of Medicine's, original definition of interventions prior to onset of a diagnosable disorder. So how do you think through this continuum of prevention right now? What are your thoughts on that?
I might take issue with the fact that people in the field might be going beyond that. I think introducing harm reduction has been a challenge. And perhaps that's really the focus of the question. Where does harm reduction fit in? I think I'm actually doing some graphics on that to figure how the overlay. I think harm reduction is the link between prevention and harm reduction operates with treatment too, because as I mentioned, there are groups that have dropped out of treatment that are not access treatment, and they are, I think in my first slide, I have harm reduction mentioned a couple of times, addressing some of the needs of those groups. I think we have to really open ourselves up. I think the fear is that it's prevention, that from people I've talked to, that prevention professionals are concerned that funding will go now to harm reduction and not to prevention. And I suspect treatment people probably have the same concerns. And yet, if we need all those services, we can see that if you look at a community, all those services are needed. It's a matter of how do we define what those are. And they're not necessarily sharp boundaries between these different, when we talk about universal, for instance, we know we're not just talking about kids, for instance, children in classes. We're not talking about kids who are not using or don't intend to use. It's a mixture of people. And I think that's how we're going to have to think about services in a different way. And that's why I think it's important to identify who those target groups are and think through what kinds of services do they need? What kinds of services do people who require treatment, who try getting into treatment and don't get into treatment, what kinds of services do they need? It's almost like we have, we just got to rethink how we're delivering services. And I think splitting us up like that and not looking at a spectrum of services is a mistake. And I'm sorry I'm talking so much, but I get very excited about some of these things and passionate.
Well, I know that I can, and I'm sure all the viewers can feel your energy and excitement for this, and we're right there with you. Thank you for sharing that. We do. We need it all. We need all of the services. And I think that you've elevated all of our ways of thinking when it comes to all services are important, right? It's important to approach them from a systems perspective and understand the various values associated with each system and how they can work together effectively to evoke change, right? And to move forward.
Exactly.
Okay. Dr. Sloboda, thank you so much for joining us today. And I want to thank all of our viewers for staying on for just a few more minutes to address that meaty question at the end. We are now going to wrap up this session and break for lunch here on the East Coast. So we will be returning at 1:30 p.m. Eastern Time. And we have posted in your chat box a link to all of the resources to help you get through today, to some of those slides, the bios, as well as the resource supplement where Dr. Sloboda has provided some very valuable resources to continue your thought process around applying prevention science in your own work. So with that, I want to thank you for attending, and we will see you back at 1:30 Eastern Time.